Welcome. I'm John Mathews with the Surgeons Group, and thank you for taking your time and attending our online seminar in regard to bariatric surgery. We're going to go through a number of issues, and hopefully this will enlighten you and prepare you for the next step in the process. So what is obesity? And it is defined as a body mass index of greater than 30. And we come up with that number. You can look on a table, you can Google it, but it's height and weight. And the CDC classifies obesity as a disease. It is linked to more than 40 different other diseases. In America, it affects 78 million Americans and many, many more that are not severely or morbidly obese. It is estimated that 1/3 of the U.S. population is obese, and it's nearly tripled since 1960. Diabetes, heart disease, stroke, arthritis, cancer are some of the comorbidities associated with it, and the economic cost to our country are astounding in the many billions of dollars. The prevalence in our country is worrisome. Since 1975, for instance, it's gone from 12% to nearly 50%, and still climbing, and the curve is not favorable. It's deadly. If your BMI is over 30, it's a very strong predictor of mortality. It's associated with increased risk of premature death, and it reduces your survival if your BMI is in that range 35 by at least two to 4 years. As I said, multiple cancers are associated with obesity, to include esophageal, pancreatic, colon, breast, endometrial, kidney cancer, thyroid, and gallbladder cancer as well. This slide, Weight Loss and You, shows the many common things that occur in our culture, but you see they are associated with morbid obesity, such as non-alcoholic fatty liver disease, diabetes, polycystic ovarian syndrome, asthma, reflux, incontinence, degenerative joint disease, and joint replacement. And so this is an excellent rundown of how it has penetrated our society. Obesity and mortality, and the higher your BMI, your mortality increases. So just you can look on here, look up your BMI, and I am 5'10", and my weight is 160, so my BMI is about 23.5. And no, I haven't had bariatric surgery, but I do work very hard, and it does require lots exercise and kind of a orchestrated, thought through program to get control of your weight. But you can do it to some degree with exercise, diet, behavioral therapy, medications, and we're talking about surgery. So the NIH came up in 1991. They said, this is the National Institute of Health, surgery is the only way to obtain consistent, permanent weight loss for morbidly obese patients. And that is very important. As you look at this, this is really a pretty astounding slide. Success rate of weight loss treatments. So placebo, you don't lose any weight. Diet, behavior modification, you might lose excess body weight in 5 years is about 1 to 2%. Medications, 10% or less, and they're very expensive and have multiple complications. But look at bariatric surgery. Average weight loss total for gastric bypass is 65 to 85%. That's quite incredible. Less than that somewhat for gastric sleeve. So bariatric surgery has been shown to be the most effective and durable treatment for morbid obesity, and it helps improve or resolve many of these comorbidities. Overall effectiveness, patients typically lose most of their weight within the first 2 years and as much as 60% of their excess body weight at 6 months and 77% by the end of the first year. Is it safe? In our hands, it's been very safe. The national literature shows the overall mortality at 0.1%, which is much lower than gallbladder surgery, hip replacement surgery, or open heart surgery. So the overall complications with bariatric surgery is about 5%. It can make you live longer. You can improve your life expectancy as well and reduce the chance of premature death. So the risk of dying from morbid obesity and its complications is much greater than the risk of having surgery, according to the National Institute of Health. Surgery decreases your long-term mortality, morbidity, and healthcare use, and that has been demonstrated in this article and in many articles.
My name is Dr. Wynn Mathews. I'll be presenting the seminar with my father and my partner, Dr. John L. Mathews. Here's just a brief article that supports what we've been talking about. We're not really going to go into great detail on that. Something that we take pride in here at Princeton is the fact that we are a MSQIP Bariatric Accredited Center of Excellence. It took us a long time to get this qualification, but it shows that we have a commitment at Princeton and have a facility that is designed to take care of obese patients and take care of patients that have undergone these surgeries that we offer. So we had talked about some of the comorbidities before. Here you can see that we can actually resolve or almost completely treat most of these comorbid conditions, and the major ones that are shown here are type 2 diabetes. About 86% of patients have complete resolution, and a lot of the patients leave the hospital off their diabetes medications, whether that be insulin or metformin or something else. Almost 80% of people leave the hospital off of at least one of their hypertensive medications. Obstructive sleep apnea gets treated as you lose weight. And then hyperlipidemia, a lot of people come off of their statins like Lipitor. Up to 80% of people get complete resolution of the hyperlipidemia. So here are some of the operations that we do. You might as well strike off the gastric band off your list. We no longer perform that surgery. We do mostly perform the sleeve gastrectomy and then the gastric bypass. The duodenal switch is something that is sometimes done, but we do not usually offer that service. So if you want to Google some things, look at the sleeve gastrectomy and the gastric bypass. We're going to breeze through the adjustable gastric band. That is something now we perform more operations to remove than we do to put them in. Again, we're going to go right through this banding slide and the complications as well. The sleeve gastrectomy is one of the 2 operations that we provide for the treatment of morbid obesity. The sleeve gastrectomy is a surgery that was initially designed as part of a stepwise fashion to the Roux-en-Y gastric bypass, but they found that a lot of people lost a lot of weight on it and has now become one of the newer mainstays of treatment. We of course do both the sleeve and the bypass robotically. You can see kind of how the sleeve is done here, with a section of the stomach removed with a stapling device and also removed from your body. The advantages of the sleeve gastrectomy is no malabsorption, so it's strictly a restrictive procedure, narrowing the size of your stomach so that you can eat less. It does result in rapid weight loss, just like the bypass. Some of the disadvantages is this is not reversible, whereas the bypass is. It does require stapling of the stomach. It is non-adjustable, and it is, while this came out, it was a newer operation, but it is now a tried and trusted method of operating. Some of the possible complications that we can see with the sleeve are ulcers, which is you're at an increased risk if you're a smoker, stenosis, bleeding, blood clot, which you can see with any operation, a leak, because this is a high pressure zone. Leaks can happen, although we have been fortunate to not see hardly any in our practice. Infections, and of course complications with anesthesia. You can see some of the other ones, but those are ones that happen commonly with any surgery. The other operation that we perform is the gastric bypass. You can see kind of a diagram there of what it looks before and after. The gastric bypass is a rewiring of your entire gastrointestinal tract so that you receive both a restrictive and a malabsorptive operation. Some of the advantages you see here are rapid initial weight loss, longer history of the operation. This is a very tried and tested operation. We do these minimally invasive, just like we do the sleeve, and it's done with the robot. You see some of the disadvantages there. It does say more operative complications, that we have not seen that in our practice. You must take vitamins and supplements for the remainder of your life with the bypass, as it is a malabsorptive procedure. It is non-adjustable, but it is reversible, although this is something that can be quite difficult to do. Some of the possible complication, you'll see that this sheet is exactly like the one we showed for sleeve, with ulcers being a little bit higher in the bypass, again, especially if you're a smoker, and then some stenosis associated usually with the ulcer. So some of the criteria for surgery: BMI of greater than 40 or BMI of 35 with other associated comorbid conditions that have been present for at least 3 years. Some of the ones you see there: hypertension, heart disease, diabetes, pulmonary hypertension, and severe obstructive sleep apnea. You of course must be at least 18 years old and must have participated in a 6 to 7 month medically supervised weight loss program through your insurance program, and usually through your primary care physician. As far as some of the things to avoid after surgery: large meals, aspirin and other NSAIDs, carbonated beverages. We usually advise not to get pregnant within the first year after surgery due to the malabsorptive and weight loss that will happen, as it could be detrimental to a child. And then drinking with meals. We will have a whole booklet on kind of how you will need to eat after surgery. We will send you to nutrition classes and other things to help you devise that strategy. Things to do after surgery: you will take a multivitamin with calcium and B12, and drink and eat plenty of protein, and keep all follow-up appointments. If you have any questions about surgery or what we've talked about here, feel free to call up the surgeons group. We will be happy to discuss these with you or at an appointment, and we can answer all your questions then. Thank you.